Share my screen. Okay. So first, there'll be a little bit of review in terms of mechanism that we've talked about. But in general, by the end of these series of sessions, today and tomorrow, I want you to be able to describe the role insulin plays in regulating blood glucose levels. That's in combination also with what we've discussed already. I would like you to describe the cellular pathways activated by insulin and explain how these can be exploited pharmacologically. So we learned about how proinsulin and insulin were made and secreted, and how that mechanism of secretion is modulated by glucose, polarization, and ATP and calcium. But now we're going to, within those pathways, talk about how drugs and treatments modulate those targets. I want you to be able to describe the mechanism of action of the major classes of drugs that are used to treat type 2 diabetes. So one of my favorite exam questions might be, tell me a drug and how it works, or in relation to type 2 diabetes, or here's a type 2 diabetic patient. How would you treat them? What drugs would you treat them with, and why, and how the drugs work? I want you to understand some of the major side effects of some of these drugs and then suggest alternatives, because, as I mentioned, there's been, over 50 years, right? Or I guess almost 100 years now of treating type 2 diabetes, originally with the discovery of insulin. But a lot of different variants and compounds have been discovered and trialed since then. So we need to understand today which ones we should use when and why, and what the side effects are. I want you to be able to explain the rationale behind the choices for the therapeutic option. So, for example, if a patient is in shock and you need a fast-acting insulin, well, which drug is that? And you tell me, oh, we use this one by insulin, fast-acting insulin by injection because the patient was about to die. And I want you to appreciate which steps. So first you give, say, fast-acting insulin, then you might give, a sugary drink or something, and then another long-term drug treatment, and be able to explain that to me and tell me what the logic is, okay? So we're going to cover in today's lectures and then tomorrow's the pharmacological treatment options for type 2 diabetes, how each of those work, and obviously the mechanisms of action and biological functions of insulin itself. We'll cover both older type 2 drugs, because you will see them in the clinic, and obviously we'll discuss more recent new type drugs for type 2 diabetes. And then again, go through the different options therein. Okay, so let's talk a little bit about pharmacological treatments for type 2 diabetes and why. And we talked about lifestyle corrections, which are obviously our first option, especially if it's a patient with mid-range glucose levels, or glucose levels. Then what do we do with we don't need to right away use drugs. So if we initiate with the lifestyle changes, but if the lifestyle changes don't work, or if it's some other, there's my QQ up. Thank you, QQ. Good morning. If lifestyle changes don't work, then the question is, when and how do we start drug treatments, and which drugs do we start using? So the main goals in terms of treatment of type 2 diabetes is to correct the obesity, okay? And obviously this, because of the physiological connections we talked about yesterday, the connection between obesity and blood glucose, we want to correct the blood glucose. Ideally, fixing the obesity would do that, but it might not, right? We might have to use pharmacological agents. Lower blood pressure, because obviously if you're obese and your sugar's high, you're most likely have high blood pressure, and then eventually lower the lipid concentrations. So if I ask you on the exam, what are the main goals of treating type 2 diabetes, I would love it if you wrote these 4 items down. Treatment strategy. First, we diagnose. Okay, remember all those tests we learned yesterday? Rapid glucose test. Oral glucose test, right? Where you challenge them. H1BAC, right? And obviously measuring the waistline was a simplistic one as well. Then we diagnose them. Yes, you have prediabetes or you have diabetes. First, we try and do lifestyle changes, diet, exercise, weight control, educate the patient. Hey, stop going to McDonald's, stop going to Burger King, stop going to the wonderful chicken place there in China. I got to look up the name of that place. I forget the name of it. Then, if the patient doesn't respond and change their lifestyle, we need to treat with some sort of compound, some sort of pharmacological agent, if we don't see any changes. We often start with what we'll talk about is what metformins and sulfonylureas, and then gradually move up the classes and types of agents depending on what the patient needs, and eventually end up to insulin, daily insulin injection or oral insulin if need be, depending again on what the patient needs. So this is your flow chart for treating a patient with type 2 diabetes. Now, remember we talked about the timing of glucose levels and before and after eating, and also obviously with age and with beta cell production. So this is above, I'm showing you a normal patient. And even in a normal patient, right, the range will be between 5 and 7 millimolar per liter, depending on if it's before or after having taken in a meal. For pre-diabetics, this range will go up. So it'll be closer to 7.5, 8. If for type 2 diabetes, it'll be closer to 10 with diagnosis at basal states in the fasting level above 6. And then obviously full-on progression will have numbers much higher than that. Insulin sensitivity patients that are pre-diabetic will also see an insulin-stimulated glucose disposal, right, that will drop down as they develop diabetes. And then you'll see plasma insulin concentration go up with diabetics until, and this was a question someone had on QQ, you get complete beta cell failure. Remember, the beta cells, they initially will try to produce extra insulin, right? But they get tired. They can't make any more. So they get this drop and this beta cell failure, and you have full-on progression of type 2 diabetes. So the challenge is when the patient comes to your door try to understand which stage they are, okay, based on those tests. And that's the importance of those tests, of fasting glucose test, and the oral glucose test, right? Because they will delineate where exactly is the patient on this progression. So that will help you define what is the first step for this patient. Where are we? How much do you expect lifestyle changes to make a difference? If the patient is all the way here and they've got no beta cell function, you can do as much lifestyle change as you want, but you're not going to get much of an effect, right? Because they don't have any beta cells. If, however, you catch them very early on, and in the left sides of these graphs, then you're more likely to have success with simple lifestyle changes, and you probably won't need to provide them with pharmacological treatment, okay? So that's why the testing side of things and the timing of the tests and the analysis of the tests are so important, because it can really save someone's life and make a big difference in terms of lifestyle. So I mentioned a couple of these in the introduction, but here are the current anti-hyperglycemic therapies available. It's obviously not completely covering all the different forms. There's a variety of different compounds of the same or similar drug on the market, but at least it's all the different families that are out there. So we've got sulfonylureas, we've got meglinotides, bioguanides, thiazolyanidines, alpha-glucosidase inhibitors, DPP inhibitors, sodium glucose cotransporters, or these SLIT inhibitors, and GLP-1 receptor agonists, and amylin mimetics. Those are probably the more recent ones of this family. And we'll go through each one slowly and talk about their mechanism of action, their side effects. So this is just a general summary of roughly how each of these drugs work and in what area they work. For example, the metformins and the glitazones typically are targeting insulin resistance, and we'll talk about how they do that. The glucosidase inhibitors typically work on carbohydrate digestion. The sulfonylureas, meglinotides, GLP-1, and DPP-4 compounds are targeting beta cell dysfunction. And the insulin replacement side of things is if you have a complete loss of beta cell mass. You have no more beta cells whatsoever. And obviously diet, exercise, and treatments, lifestyle treatments for obesity and then the dyslipidemia will also function, assuming that you still have beta cells and some of these other mechanisms functioning somewhat. But before we discuss how these drugs used work, I just want a quick reminder on some of the things we've talked about, because it'll be important for you to understand in understanding how these drugs function. So let's just quickly go through some of the key points that we've talked about, all right, in terms of insulin mechanism. Insulin is the only hormone that can cause hypoglycemia. There are multiple hormones that counteract the effects of insulin and increase the blood glucose. So what does this slide tell us? One, it tells us how important insulin really is. And two, this importance is highlighted by the number of regulatory mechanisms and compensatory mechanisms within the body to counteract and slow or dull insulin's effect. So here are just a few: glucagon, noradrenaline, cortisol, and growth hormone. All of them are known hormones that counteract the effects of insulin and increase blood glucose. So this tells you, one, how important insulin is, two, how important it is to reduce hypoglycemia, and three, some of the mechanisms that we can use or exploit in terms of pharmacology to treat hypoglycemia. Remember, insulin affects glucose uptake in most cells, increases glucose use and storage, increases glycogen synthesis, increases protein synthesis, increases triglyceride synthesis, and gene expression and growth. The stimulus for secretion of insulin is acute increase in blood glucose, and its main effect is then to decrease blood glucose. It's going to drive down gluconeogenesis, drive down glycogenolysis, drive down proteolysis, and drive down lipolysis and lipid oxidation. As a reminder, the insulin receptor is a tyrosine kinase receptor. It has 4 chains, 2 alpha chains and 2 beta chains. Insulin binds on these cysteine-rich domains. You then get cross-phosphorylation and recruitment of signaling molecules on the inside, which then propagate the signal across the cell, which then drives all the effects that we've discussed and talked about. So it binds to the insulin receptor. This multimeric tyrosine kinase receptor has these 4 subunits that I talked about. Insulin specifically interacts with those cysteine-rich domains, and it evokes this intrinsic tyrosine kinase activity. Downstream targets include these IRS proteins, 1 to 4. And remember, some of the mutations in the IRS proteins were responsible for the monogenic diabetes. If you remember, we talked about that yesterday. So now let's see if I can get this little video to work. There we go.
Cell membrane, so it has a part outside, a part cell membrane, so it has a part outside, a part inside.
Doesn't like my volume.
And insulin binds to the part that is outside. Insulin is a small molecule whose structure was determined a long time ago, in 1969. But it's been unknown how to interact with the receptor, and that is what we have discovered. And its interaction are characterized as a molecular handshake, as the 2 proteins dock together. When insulin binds to the outside part of the receptor, it brings the 2 halves of the receptor together, and at the same time, the 2 parts inside the cell unwind and make contact. These two proteins then activate each other.
This activation allows the insulin signal to enter the cell. Specialized proteins interact with the activating receptor just below the cell surface. The receptor activates these proteins, and they in turn are able to activate multiple other proteins in a long signal cascade. This complex signaling process eventually tells the cell to take up glucose for use as an energy source. The long signal cascade allows tight control of the signaling process, as it can be turned on or off at many different points along the way. In type 2 diabetes, we believe insulin binds to the receptor normally, but the signal is not sent into the cell and the signal cascade is not developed. This is known as insulin resistance. This means that glucose cannot enter the cell and blood glucose remains high. Over time, high glucose levels damage many different organs.
So, obviously in that video, which I think is really cool and well done, it's a bit older now, so that we appreciate a bit more all the intracellular mechanisms that occur, but one of them to drive insulin resistance can be caused by some of these mutations that I talked about in these IRS proteins. So you can see this IRS complex serves to have a polyphosphorylation of all these tyrosine residues, and you can imagine that if there are point mutations there within that somehow inhibit interaction or phosphorylation or problems with expression of PI3 kinase or GRAB2 or SOS or this SHC kinase, then you might anticipate you might get genetic causes of diabetes. Or imagine if you have expression changes that are physiologically driven, then the same would occur. Now, remember some of the downstream consequences that we talked about. Once insulin binds to its insulin receptor and this downstream signaling cascade occurs, you get activation of transporters to allow and facilitate glucose uptake. You get increase in the glucose storage and oxidation via this series of protein phosphatases. You get changes in protein synthesis and proteolysis, in part through interaction with translating machinery within the cell. And in addition, you get, because of this upregulation of enzymes involved in lipid metabolism, which are then going to impact your lipolysis and triglyceride synthesis. And finally, eventually, you will get gene transcription and growth changes. So again, we saw this slide earlier, but it's important to keep it in mind and remember it, that the major targets of insulin are the liver, adipose, and skeletal muscle, and it tends to affect all major metabolic pathways within these, be it carbohydrate, fat, and protein. No insulin, you start to see for those with loss of beta cell mass or beta cell exhaustion, you get fatty acid oxidation and lipolysis and gluconeogenesis. The net effect is to cause hypoglycemia in terms of insulin, and increased fuel storage in muscle, fat, tissue, and liver. So the individual effects of insulin on the liver, hepatic cells is to decrease gluconeogenesis, decrease glycogenolysis, decrease ketogenesis, and increase glycogenesis. This is a good review slide for you to just for an exam. Its effects on muscle, here is where it really impacts the glucose transporter alters the amino acid uptake and protein synthesis. Obviously, protein synthesis a major aspect for muscle cell function. And in terms of the fat, and why one of the reasons we have fat, the direct relation with fat tissue and insulin and glucose is the following: is insulin's effect on fat is to increase glucose uptake, decrease fatty acid and glycerol release, and increase triglyceride synthesis. In terms of actual carbohydrate metabolism, we get glycolysis increased, right? And this is through enzymes. Just to remind yourself of your biochemistry: phosphofructokinase, glucokinase, and pyruvate kinase. Glycogenesis is increased through glycogen synthase. The pentose phosphate pathway is increased through glucose 6-phosphate dehydrogenase. Gluconeogenesis is decreased by modification of pyruvate carboxylase, phosphoenol pyruvate carboxyl kinase, and glucose 6-phosphatases. And then glycogenolysis is decreased by targeting the glycogen phosphorylase. So these are all some of the targets, the downstream targets of insulin receptor. What about enzymes impacting lipid metabolism? For lipogenesis, you're going to have the causes. Remind yourself, de novo fatty acid synthesis is going to be increased, and it's through the acetyl-CoA carboxylase, and obviously its related substrate, NADPH. And in the adipose tissue, you're going to have lipolysis occurring, which is going to drive, which is going to be decreased, whereas the adipose tissue net effect is increased. The enzymes for lipolysis are usually hormone-sensitive lipases. For ketogenesis, it's decreased, and this is through HMG-CoA synthase. And for lipoprotein, they're increased, and it's through the utilization of VLDL and LDL. Why am I telling you all these enzymes? Because some of the drugs that we'll talk about target some of these enzymes, and that's why I want you to remember and appreciate the connection. For protein metabolism, it's through protein synthesis, typically of RNA polymerase or amino acid uptake. And for protein degradation, it's decreased through targeting transaminases and deaminases. Okay, so I've described the role insulin plays in regulating blood glucose levels. And we've talked about the cellular pathways activated by insulin, and talked about, and now we can discuss, we've talked about how they can be exploited pharmacologically via the enzymes that I mentioned to you and mechanisms that I mentioned. Now we're going to talk and start to introduce some of the mechanisms of actions of some of these drugs that I mentioned in relation to those targets that I just outlined to you. Okay, so let's start with the sulfonylureas, one of the older family of proteins, of compounds. Okay, just to highlight how many of these there are around. So these are some of the oldest drugs on the market for type 2 diabetes, and actually some places they're not even on the market anymore. But just to highlight how much medicinal chemistry and pharmacology has gone into this family of compounds and the point of these sulfonylureas is to stimulate beta cells to produce more insulin. Okay, so obviously this is for early pre-diabetic type 2 diabetics, right? Sulfonylureas do absolutely nothing for a type 1 diabetic because they don't have beta cells. Okay, so don't write on the exam, treat a type 1 diabetic with sulfonylurea because you will fail. Same thing, if I tell you the patient has no beta cell or complete beta cell exhaustion, then sulfonylureas are not the compound to choose. So, first generation sulfonylureas are one of the first ones was this called butamide, and it's this. So this is the core background of the sulfonylurea here. You've got a benzene ring with this sulfonylurea group, and the chemists figured out you can modify either R, this substituent, or R1 coming off the nitrogen. You can modify coming off the ring or the nitrogen, and then tolbutamide is probably the most simple in terms of adding on the ring with a bit more of a longer tail on coming off the nitrogen. Then was developed later this tolinase or tolazamide, and finally later this chloropropamide. Then more recently, it was appreciated that you had you could produce slightly better modifications in this glipizides. So you see here the glipizide, they figured out you could modify this ring somewhat, take out the sulfur group and shorten the tail, and you can still get a nice effect. So they started modifying these glipizides, and these are all glyburide, micronized glyburide. You can see glyburide here is taken out and added a chlorine group, and but maintains very similar backbone to the glipizide. And then finally, and this is the second generation, and then the third generation looks a bit more complicated in terms of synthesis, but they basically figured out you can alter the cyclization of this group and obviously start modifying it with this R1 compound, and there's actually a few more variants of this, and this is the third generation glyburide. Now remember, just a quick medicinal chemistry for you, sometimes companies make variants only for intellectual property protection, not because necessarily it's a better compound. That's important from a physician standpoint. You are going to be doctors and physicians in the hospital. It's important to appreciate that older compounds often work just as well as new ones. New ones oftentimes are only there because the company wants to make money and patent the product and protect it, right? So I just want to make that point that yes, okay, sometimes the older compounds, the first generation compounds, might have higher side effects and the new ones less side effects, but oftentimes that's not necessarily the case. Now, there is generally an increase in relative potency in the first to the third generation of compounds. Okay, so in terms of potency, you can see going forward, you have this amylyl glymeridide is 350 times more potent than tolbutamide, but tolbutamide still works. You just have to treat the patient with enough of it. Obviously, the potency is useful because you can decrease the doses, but you're still at risk of side effects if you go too high in terms of doses for the patient. So how do they work? All of the sulfonylureas are orally active, and typically they bind to plasma proteins, which is good in terms of drug delivery. You can at least deliver them via oral routes. The chloropropamide is a very long-acting first-generation drug, whereas the other variants are less than 24 hours. So again, it's important to understand and appreciate what is the situation of your patient. Do you need long-acting or do you need fast-acting? As I mentioned to you, the second generation compounds and third generation are more potent. The glipizide is a relatively short half-life and is thus considered in many ways the safest. This glimepiride is a new drug, relatively new. It's newer. I wouldn't say it's new now. It's long-acting and approved for a concurrent use with insulin, which is attractive for patients which are being treated with insulin substitution. So it is a handy version of the sulfonylurea. Okay, so how do these sulfonylureas work? Apologies, this seems really out of focus, this slide. I don't remember it being quite so out of focus. Okay, just a reminder sorry, kind of a terrible slide. Just a reminder, remember that the glucose, in the resting state, you have low glucose, and it doesn't really activate this GLUT2 channel, and you don't have much change in ATP. But in a glucose-stimulated state, remember, in our beta cells, high glucose is going to bind to this GLUT2 channels. It's going to drive ATP production and drive metabolism, activate those mitochondria. It's going to, remember, through all this pathways, we release the first 5%, right, of the channels sitting there, and then another 95% are going to start to, we're going to start to make that proinsulin. We're going to start getting those proinsulin peptides into our vesicles. Those vesicles are going to bind to kinesin. Kinesin is going to walk up like a penguin up those microtubules and then prepare to get released. And then meanwhile, the ATP is going to depolarize this potassium ATP channel. It's going to close it, depolarize the membrane, and this voltage-gated calcium channel, which is sensitive to this membrane depolarization, will open. Calcium influx comes in, and this will then drive that 95% release of those vesicles. Okay, so where do the sulfonylureas come into effect? Well, they are responsible for modulating that ATP-sensitive potassium channel. So sorry, this was a better slide. So essentially, we're reversed now. So glucose binds as GLUT2, ATP goes up, and it should modulate that ATP-sensitive potassium channel to depolarize the membrane, but sulfonylurea binds that channel, okay, and alters, and so that ATP can no longer bind it, and alters the ability to depolarize the membrane, so you don't get that 95% release that we saw earlier. So the primary mechanism of action is to stimulate endogenous insulin release. It binds the ATP-sensitive potassium channel to inhibit the opening of the channel, similar to ATP. Okay. So the secondary mechanisms of action of these drugs is they are sensitive beta cells to these drugs. They decrease lipolysis. They sensitize beta cells to glucose, apologies, and they decrease lipolysis and decrease clearance of insulin by the liver. Okay, let's take a quick break because I can already tell I think I made a mistake there, so we'll have to start that slide over. And I'm going to get another coffee, and I will be back in, say, 15 minutes, 20 minutes.